Hello everyone, Dr. Alex Vasquez here, and right now I am going to provide the fastest possible review and critique of this article. So I am going to probably type out the transcript of this review. So this is going to be called Critique of Effect of a Single High Dose of Vitamin D3 on Hospital Length of Stay in Patients with Moderate to Severe COVID-19, a Randomized Clinical Trial. This was just published yesterday, February 17th, 2021. Today is February 18th, 2021. So, like I said, I'm going to do this as fast as I can. This is another disaster of a study. So, well, I don't know if I can call it a disaster. From a nutritional standpoint, it's a disaster. From the perspective of medicine, it's a disaster. From the perspective of pharmacology, everything we know about nutrition, microbiology, immunology, it's a disaster. But to make nutrition look bad, it's reasonably successful because most people don't know how to read nutrition studies. And this is a really good example of an article that the majority of people won't read properly. So I'm going to show you how to read it properly. And I have some unpleasant things to say as we go through this, but I'll explain. I mean, I'm not going to be rude when I say what I'm going to say, but I am going to say some things. I've said it before. I'm going to say it again today. The efficacy, I scratched it out. It says the efficacy of vitamin D3 supplementation in coronavirus disease is unclear. It's not really unclear except with garbage research like this. So what they did here is they had a large group in the placebo and the vitamin D3 group, 120 per. That's pretty good. Patients were assigned to receive a single oral dose of 200,000 international units of vitamin D3. So that's called bolus dosing. So before you can even get, I mean, you can only get 1, 2, 3, 4 lines into this. We're already on the 5th sentence of this article, and you already know it's designed to fail. You already know it's designed to fail. How do you know it's designed to fail? Because you read the meta-analysis published in the British Medical Journal in 2017. So this is 2017. At that time, vitamin D supplementation to prevent acute respiratory tract infections. Vitamin D supplementation was safe and it protected against infection overall. Patients who were very deficient and those not receiving bolus doses experienced the most benefit. So we already know that when vitamin, and I'm going to show you the pharmacology on this, so we already know that we have no confusion around this topic, but I'm going to clarify it yet again. I did publish an article on this topic in December of last year, so that was just 2 months ago. Called kind of the death of the vitamin D bolus. So here we are, and this is why. So vitamin D does not function acutely when it's delivered in bolus doses. If you want an immediate effect within hours and days, you have to use the kind of well, it is the active form. I was going to say semi-active form, but you have to use 25-hydroxy vitamin D, not just plain vanilla vitamin D. Because of the pharmacology involved. So, again, British medical, no one could have missed this who studies this topic. And they cited this study. So they were aware of this. They knew that vitamin D bolus was going to fail, and they used it anyway, and then they said it failed. Well, it didn't fail. If something is already known to fail, and then it gets used again, the failure isn't the treatment. The failure is the investigators. Average age 56 years old. Baseline vitamin D was 20, call it 21 nanograms per milliliter. That's clearly deficient. It's not horrible. I mean, I've seen worse, but it is deficient. Length of stay was not different between the two groups. Vitamin D and placebo was not different for in-hospital mortality, admission to intensive care, mechanical ventilation. So here's here's the second misrepresentation of data. So the first misrepresentation is that they used misrepresentation of knowledge, misrepresentation of anything reasonable. They knew this was going to fail before they did it. They did it anyway, and it failed. And it's just that's unethical. It's unethical. It's a waste of patient experience. For patients who died, it's a waste of patient lives. It's a waste of all of the talent. Let's assume these people have talent in something. It's obviously not doing vitamin D research. Let's assume they have talent in doing something. This distracted them from using whatever talents they may have while they were wasting their time with this study. Vitamin D, serum vitamin D levels significantly increased after a single dose. Most of you are going to read that and you're going to accept it for what it says, but I'm telling you that's deceptive. And I'll show you why. I'm not making any of this up. I've got three. I only need 3 citations to completely demolish this study. The first one is, we already knew, according to a meta-analysis published in 2017 in the British Medical Journal, that everyone in the world has read this study if they're interested in vitamin D. And we already knew that the bolus dose didn't work. That's consistent with a lot of other research in other fields, always showing that the bolus doses are either less effective or actually negative in their consequences. So we already know this. They should not have used this study design. Other aspects of the study were actually okay. With randomization of patient groups, things don't always divide out equally. And in this study, things did not divide out equally. But that's not necessarily the fault of the researchers. If they randomized, let's look at it right here. If they randomized competently their patients, the randomization just didn't work out very well. And what you notice, I realize I'm skipping ahead, what you notice with their randomization is that the patients in the subjects or the patients in the vitamin D group, they were sicker than the patients in the placebo group on things that matter. I mean, some of these differences, they don't matter that much, but on the things that matter, the patients in the vitamin D group were sicker, more sick. We'll get back to this page in just a moment. Back to the first page. So already, but before they even treated their first patient, their study design was wrong. We already knew it. Everybody knew it. It was published in a British medical journal meta-analysis. I mean, what more could you ask for? They say that serum levels normalized, and they use that as evidence of the effectiveness of their intervention, and it's completely wrong. I'm going to show you why. If it's not clear to you by now, then you just don't know the pharmacology of vitamin D. And I'll explain to you the pharmacology of vitamin D. Among hospitalized patients, length of stay did not change. These findings do not support the use of high-dose vitamin D3 for treatment of moderate to severe COVID. You're going to see how horrible this study is. I mean, this is an embarrassment. I think this is stupid. And I actually like the word stupid. And I use it in some rather specific ways. But I define stupidity as someone not acting in accord with their level of knowledge or the level of knowledge they should have, right? So if you've got PhD, Master of Science, Bachelor, PhD, MD, Master of Science, MD, PhD, MD, PhD, MD, PhD, and then this was reviewed by at least 2 or 3 reviewers at the journal. So most of those would be doctorate level people for sure. So let's say another group of 3 MDs and PhDs, and then the editor of the journal, and maybe the associate editor too. So then let's just add 5 more MDs and or PhDs. These people are not behaving in accord with the level of knowledge and skill they should have if they're at the MD PhD level. I mean, this is not MD PhD level work. They They used the wrong intervention. We already knew this was going to fail before it was ever started. It's a waste of resources. And it's just wrong. And this part is just wrong. So on page number 1, the errors, the obvious errors, are their design. We already knew this was going to fail. And their misrepresentation here, it's very subtle. And I'm not even saying that they did it on purpose, but it is a misrepresentation of the intervention. And I'll show you that in just a moment. So they excluded people who had previously taken vitamin D. That's fine. They just wanted vitamin D deficient people. They used whatever testing method they did. That's not the focus of my review. So here's another. Some of these errors are subtle and small, and some of them are big and major. So here's one. I'll put this in the small category. The vitamin D group received 200,000 international units of vitamin D. 200,000, obviously a bolus dose. So these patients were followed for 10 days. And let's say that 10 days is kind of the duration of the super acute infection, at least at the start. So that would be an average of 20,000 international units per day. That's nothing heroic, people. That is nothing heroic. If over the course of 10 days you administer 200,000 units, in this case they used a bolus dose, that's 20,000 units per day. That's equal to about half a day of sunbathing at the most, right? So this is not heroic. This is not a major heroic intervention by any standard whatsoever. Now, for people who don't understand nutrition, they'll look at 200,000 and they'll say, well, my goodness, the recommended intake is 400 or 800, which is stupid. So this is huge. This is massive. This is overdose. This is supraphysiologic, supranutritional therapy. And it's not. This is totally within physiologic norms. They didn't do anything great or heroic here. This selected dose is in the recommended range. Yeah, it's in the recommended range, but it's at the low end of the recommended range if you're trying to get an acute effect rapidly. And it's not really the proper form for an acute response. So is it in the range? Yeah. The range is about 100,000 to 200,000, 300,000, 500,000, 600,000. So they could have used more and still been within the range, but they used what they used, and it's physiologically acceptable, certainly not heroic. For effectively treating patients with 25-hydroxyvitamin D deficiency. So here's what they're saying. I am going to quiz you as soon as I describe this, and I'm describing it right now. So what they're saying is that this dose is appropriate for correcting vitamin D deficiency. Okay? Now, how many of you agree with that in this setting? I mean, obviously, if I'm asking the question, it's because I don't agree with it. So that tips you off to the answer. These are not normal patients with vitamin D deficiency. I'm sure we all agree with that. These are acutely ill patients. So if they're using a dose that's appropriate for normal healthy people, but they're using that dose in acutely ill patients, then they're wrong. So these patients were sick, disproportionately symptomatic, and disproportionately ill compared to the other group. And all of these patients were obese. So their justification for using that dose, because that's appropriate for the treatment of vitamin D deficiency, you can't use a dose appropriate for normal, healthy, normal weight people and then use that dose in acutely ill, obese, disproportionately sick patients and then say that that's still okay. It's not okay. So these patients are deficient and sick. That's not the same as just being deficient. Another interesting point. So I just reviewed, today's Thursday. On Sunday morning, I reviewed another study conducted in the same time frame as this study. And the other study said, oh, well, we had so much problem recruiting patients, we couldn't get any patients. Well, in this study, they were able to recruit more patients than they expected. So how, in the same pandemic, in similar study models, one group said they couldn't get enough patients, and this group said they practically had too many? Okay, so interesting how selective that can be. So here's another. Let's I'll make a mental list, because I have some complaints about this article, but I also think this article is completely discredited. Number one, it's discredited because they knew from the outstart that bolus dosing wasn't going to work, based on a 2017 recent BMJ meta-analysis. It's not going to get much better than that, folks. They already knew this was going to fail. They did it anyway, and JAMA, of course, published it, of course. Here, look at this. Time from symptom onset to enrollment was a little bit more than 10 days. So they delayed treatment for a week and a half. That's unheard of. So if you have watched my other reviews, in which usually I'm a little more calm than I am now. I had some really strong coffee this morning, and it was good. If you look at my other reviews, I have said before, what they do in these nutrition studies would never be allowed in any drug study, in any legitimate good drug study in a legitimate good journal. They would never publish it. I mean, the reviewers, the editors would say this is garbage and it's unethical. It's unethical to delay treatment for a week and a half and then say, oh, well, we're okay. So they did this twice. They did it intentionally here, as you can see. They delayed 10 days, and then they did it probably without intending to. They had another delay in their. They had another delay in their process. I'll show you that. So, for example, let me make this super clear. For those of you who need examples, you're about to get one. If this were a study, for example, of patients with osteomyelitis or necrotizing fasciitis or sepsis or pyelonephritis, a kidney infection, and the investigators waited 10 days to start antibiotic treatment, and then they said, oh, well, it either worked or it didn't work. The first thing you should be thinking is, how could you have possibly delayed treatment? What was the reason? What's the rationale for delaying treatment in something that's time sensitive? Look here, all these patients are obese. So this is another, in my opinion, this disqualifies this study. Now, they could have retitled the article. They could say, delayed use of vitamin D3 to account for the fact that they delayed it by a week and a half. They didn't say that. They just say high-dose vitamin D, and then they make a generalization that their findings generalize to anything. This is insane. So disqualification number one was their dose administration. It's completely wrong. They knew 4 years ago that this was wrong. In my opinion, if I were the editor or reviewer of this paper, I would have said this. There's no way you can do this. They had a lag time here from a pharmacologic standpoint. So okay, so let's just say treatment lag. Between the physiologic lag and the kind of structural lag, they had a tremendous lag, at least of 2 weeks. So from the time patients were sick to the time they were actually receiving benefit from the intervention was a period of 2 weeks. All of these patients are obese, so they're going to need more vitamin D. How do these patients become obese? How do people become obese on a population-wide basis? One of the ways is by eating ultra-processed foods. So were these patients deficient in magnesium? Probably so. Therefore, could their bodies even use the vitamin D that they're receiving? Probably not so well. The vitamin D group was definitely more sick than the placebo group. That may have been intentional. It may have been a mistake, but it's obviously it's right in front of you, and you can't say that the groups were equivalent because they weren't. let's keep going here. They tracked about the same, and that is the conclusion that they came up with. It's just the wrong conclusion from the wrong intervention. One patient got an extra dose of vitamin D. That's okay. They had more than 100 patients, so the percentages are going to work out just fine if, give or take a little bit. All of their patients were obese. Time from the onset of symptoms to randomization was 10 days. How could, I don't even know how they did that. I mean, how could they do that ethically? How could you have a sick patient and then say, come back in a week and a half? Or maybe the patients presented and then they said, oh yeah, well, I was already sick for 10 days. For example, I'll give you an example. I mean, it's not fair. It's not right. If you look at the studies, for example, justifying Tamiflu, the nearly worthless antiviral drug that's used in influenza, which the American government has spent millions of dollars on, it has to be administered within the first 24, 48 hours, right? After that, people would say, well, it doesn't work. So when they want to justify spending millions of dollars on a drug, then they're Johnny on the spot. We have to administer this within 24, 48 hours. We're professionals. This is what we do. But when they want to do nutrition studies, they just throw out any knowledge. And they say, with a drug study, 24, 48 hours, boom, from symptoms to drug administration, we are Johnny on the spot. And when they study nutrition, they're going to wait a week and a half. All these patients are obese, so they're going to respond less to treatment. They had a slight hazard ratio in favor of getting discharged in the vitamin D group. I don't think I've ever seen a study that talked about a hazard ratio for something good. Usually hazard ratio is something bad. That's why it's called a hazard ratio. It's not a benefit ratio. In this case, they totally inverted the language and they said, oh, well, there was more risk for being discharged. Well, but that's a risk you would want. Okay. Vitamin D was low, typically around 20, and it increased to 44. But not in everybody. It didn't work in everybody. So here's the other thing. In the vitamin D group, had levels above this. Okay, so 14% of their patients did not respond to the intervention. 14% did not respond. I'm going to write a note. 14%, 14% no response. Well, how do they account for that? I mean, that's pretty big. If you're talking about a little bit more than 100 patients per group, that's 14 patients who didn't respond, or maybe more. I mean, you can't just say, well, that doesn't matter. It does matter. It means your treatment didn't work. Why didn't it work? Because these patients were deficient and they were all obese. All these patients all of them were overweight, and the average here, this is obesity. This is obesity. The vitamin D. Okay, so now I'm going to teach you about pharmacology. So vitamin D levels were measured on the day of randomization and on the day of discharge. That was typically observation time, but I think that they said that the total duration was typically 10 days. Well, here they say 7 days and 7 days, but I thought I had seen 8 days, 7 days. I thought I had seen them say 10 days somewhere in one of these charts. Maybe it was the delay of 10 days. Maybe that's what I'm thinking of. Anyway, here's my point. If they want to say it was 7 days, let's go with the shortest duration possible. In this case, because it will be to the advantage of the authors that I assume it's short. I thought I had seen it say 10 days. So, what do we do with that? Yeah, so they used vitamin D3 bolus dosing. And let's say over the course of 7 days, they saw that their vitamin D levels normalized. Well, let me explain to you what that really means. What it really means is that the patients were deficient for the duration of that time, and they were overloaded with vitamin D3, which is the inactive metabolite. So I'm going to close out that. We've seen it already. I think this is the one I want to look at. So this is a great study by Robert Heaney, of course, the late Robert Heaney. This was published in 2008, so now we're in 2021, so this was 13 years ago. So these authors missed this study from 13 years ago. They missed the other study from 4 years ago. This is crazy. So here's what we know about vitamin D3 when it's administered in high doses. So here they used 100,000 international units, 100,000. In the study that we're looking at, they used 200,000. So this peak would be even higher. So here's what happens. When vitamin D3, and this is exactly what is shown here, when vitamin D3 is administered, it has to get converted into the more biologically active form, 25-hydroxyvitamin D. This is the biologically important form. But that doesn't happen immediately. And here you can see over the course of 10 days, vitamin D3 levels peak. Now remember, this is an inactive metabolite that actually blocks 25-hydroxyvitamin D3 activity. So when you see this level going up, this is not good. This is bad. You don't want this level to go up. And at 100,000 international units, it goes up to 500. With 200,000 units, it would have gone even higher. So this has a suppressive effect on vitamin D function. So these patients became sick. They had to wait 10 days for treatment. Actually, another day on top of that. So 11 days for treatment. And then they received treatment, which was the inactive metabolite. So they were spiked with the inactive metabolite for the entire duration that they were hospitalized. But the doctors, the researchers of the study that we're critiquing right now, they didn't even look at this metabolite. They only looked at this, the black circles, and they said, oh yeah, well these patients normalized. They weren't normal. First of all, they would have only normalized on the last day or two of their 7-day observation period, 7 or 10 days. But while they were so-called normalizing here, this would have been outrageously elevated, and this is an inactive, actually inhibitory metabolite. So this is the pharmacology of vitamin D3. When you give it, it goes high and has an inhibitory effect while you're waiting for this to normalize, so-called normalize. But you have to measure both if you're going to get a clear picture of what's going on. These researchers of the study that we're looking at right now, they only looked at this line. They ignored this. How could they ignore this? This is from the American Journal of Clinical Nutrition 13 years ago. This is the study that defines the pharmacology of the intervention that they're using, and the researchers being critiqued right now totally skipped this research. Inexcusable. 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 So when you look at vitamin D administration, typically you're looking at waiting 5 to 10 months to normalize 25-hydroxyvitamin D levels. This was also published 2019, so relatively recently. But it doesn't matter because this is data from Robert Heaney again back in 2003 or 2008. So sure, this particular article was published in 2019, but this data showing that normalization of 25-hydroxyvitamin D levels, this was published 15 years ago. This is a really nice report. Journal of Steroid Biochemistry and Molecular Biology, 2019. Really nice report. I like this one a lot. Let's go back to this. And this is a disaster. But most people don't understand vitamin D well enough to critique this article. I do. The bolus dose was wrong from the start. The bolus dose spikes or peaks the D3 level while the 25-hydroxy level is normalizing. But you got to look at both of those numbers if you're going to have an honest evaluation. Placebo group. Okay. Lack of clinical benefit seen. Yeah, well, they gave too little and it was too slow. So they had 2 lag times in this publication. So here's my note to myself. In medical pharmacology, we would always account for any lag time. But when they are studying nutrition, they never even mention the consideration of a lag time. And here it was definitive in the outcomes of the study. So number 1, bad study design. Number 2, they delayed the randomization by 10 days, and then they had another 1-day delay. So that made it, I'm sorry, did I say that correctly? By 10 days, and then another day to make it 11 days. So they waited 11 days to intervene. But then the intervention itself had a lag time of about another week. So they waited 11 days from symptoms to implementation of treatment, 11 days. And then you have to add really another week to normalize things again. So that makes it 18 days. I mean, we're close to 3 weeks of, and that would be the absolute soonest it could happen. So let's just call it 3 weeks. From symptom onset to receiving body-ready vitamin D was a delay of, let's just say, 3 weeks. I mean, that's absolutely negligent. Absolutely negligent. So they gave them too little, too late. They measured everything. They did it. This is a really nice study, except for the things that they missed. I mean, they did a lot. I mean, they did good. But the things they missed were the difference between success and failure, and that's why the study failed. So see their conclusion? These analyses indicate that a single oral dose of 200,000 international units of vitamin D can rapidly increase 25-hydroxy as long as you ignore the serum levels of vitamin D3. So the present null findings cannot be attributed to the failure of increasing vitamin D, 25-hydroxy vitamin D. They measured these on the day that patients were discharged. So they gave themselves every possible cushion to arrive at this conclusion, which is, in my opinion, completely wrong. I mean, it's wrong ethically and it's wrong technically. Discussion didn't work. And because the patients had several coexisting diseases, patients were given a dose. A relatively long time from symptom onset to randomization, average of 10 days. Then they had another 1-day delay, so that makes it 11 days. And then once they got the vitamin D, for the vitamin D to become appropriately activated and for the serum vitamin D3 level to get reduced, because it is an active, a negatively active metabolite, that would have been another week and a half. So they had a week and a half delay to get started and a week and a half delay to start receiving benefit. Here's the other thing that's very important. All of the benefits of vitamin D are not realized on day number 1 of having a normal vitamin D3 level. First of all, let me qualify what I just said, because these patients barely became normal. Look at how they define this here. Achieved vitamin D, 25-hydroxy vitamin D sufficiency, defined as this, 30 nanograms per milliliter. Excuse me again. That is not normal. That is not optimal. No one should aim for that. I mean, that's not even right. So that's what I mean with my note here when I say too little, too late. That's not physiologically normal or optimal at that number. So that's what I say again. The onset of benefit was too little and it was too late. These analyses indicate this, and they're wrong. They're wrong. They didn't look enough, and that's why I say this is a stupid and self-serving conclusion. These are stupid mistakes to be made at the MD, PhD level, and then you have to add on another 5 reviewers and editors and associate editors. I mean, these people are not acting at the doctorate level, and they've got, 15, 20 MDs and PhDs among them, and this is not competent work. But this is typical of what we would expect to get published in JAMA. That's probably all I have to say. They had to wait a long time. Yeah, so they waited 10 days. They waited another day to actually get the treatment. Then they had to wait another 10 days for it to work. So that's easy. That's 21 days. That's 3 weeks from symptom onset to effective treatment. But like I was saying, normalization of serum levels in obese patients doesn't equate to a miracle response. It's not like the body says, oh, man, now I've got the normal blood level, which isn't even normal here. Now I've got this new blood level and I'm perfect. They're not going to go from deficient to perfect in the setting of multiple diseases, multiple drugs, and obesity at the same day. You're talking about the transcription of 3,000 different genes. You're talking about changing their gut microbiome, and that doesn't happen overnight. That's the difference between preventive dosing of vitamin D3 that takes place over 3 months, 6 months, versus these acute dosing studies. I mean, even in the best of situations, they're lucky to get a response just based on the pharmacology of vitamin D because it's not an instant cure. That doesn't mean it doesn't work. That doesn't mean it's not beneficial. That doesn't mean it's not cost effective. That doesn't mean that all of nutrition is a waste of time. It means it works, but you have to let it work, and you can't expect something which by definition is going to take 3 to 6 months to even normalize tissue levels. I mean, that's what's shown in the data. It's not even, I already showed you that data. It takes 5 to 10 months to normalize tissue saturation, let alone changes in the gut microbiome. And these people want a response in 3 days after they waited 11 days and then another 10 days to even normalize their levels. I mean, this is absolutely absurd. So par for the course with the medical insanity that's going on right now. That's the conclusion of my review. If you need to see it again, you can see it again. Number 1, this study should have been disqualified based on faulty design. Disqualify again by delaying treatment for 10 days. Disqualify again by the pharmacologic lag time of another 10 days. And another 1 day of administrative lag in there. So they had a lag of 3 weeks between symptom onset and effective treatment. At the best. I mean, I'm not even saying that would be expected to work. So bad design. They knew the treatment was going to fail. They had a 21-day lag time. And like I said before, their patients in the vitamin D group were sicker than the placebo patients. So this study is just horrible. But these are the kinds of studies that get published in JAMA, and they get picked up by the news headlines. And this study will impact millions of people. And that's horrible.